Hi everyone, this is another in our series of Tell Me in 10, which is a 10-minute talk telling you about different aspects of imaging. This is again dedicated to all the residents out there who are fighting COVID and to help you learn as you go along the way. So today we'll discuss differentiating benign and malignant fractures of the spine. Um, Essentially, the overview is that benign or osteoporotic fractures are resultant of a weakening of the bone, and the underlying bone is weak but otherwise normal. On the other hand, a malignant compression fracture is one where the vertebral body gets filled with abnormal material, loses integrity, and therefore collapses. There are 5 key differentiators between these two: the presence or absence of a fracture line with retropulsion or convexity, multiplicity of these fractures, spared marrow signal, posterior element involvement, and focal paraspinal masses. And this is how we're going to go about discussing the differentiation of these structures or of these different types of injuries. So the first thing to think about when you differentiate different vertebral bodies is to think of a cardboard box. So you could have a cardboard box with a solid stuffing, such as being filled completely with books. And in this case, when you sit on it, nothing happens to the box. And this is probably your normal vertebral body. On the other hand, you can have an empty cardboard box. And if you sit on this, then you can remember that the cardboard box just crumples. And when this crumples, you can see a crack along the middle of the cardboard box when you sit on it. And you can see that there'll be buckling of the sides completely. And this is in keeping with what we would call an osteoporotic vertebral body. On the other hand, you could have a vertebral body that's stuffed with, let's just say, styrofoam balls. So this is soft material that is inside, but it's all over the vertebral body. And when you sit on this box, it sort of just bulges at the sides rather than completely collapsing. And that is the situation with a malignant fracture. So how does this identify, or how does this show up on our imaging? On imaging, when you see somebody who's got an empty cardboard box or an osteoporotic fracture, you can see the fracture line really clearly. And so this is what happens. You actually load on the box. You can see the fracture line really clearly. So there's the fracture line on the T2 weighted images. And you can also see retropulsion of the posterior superior end plate. And this is pretty typical and classic for a osteoporotic compression fracture. On the other hand, in somebody who's got a malignant fracture, you can see here in the T11 vertebral body that the vertebral body is slightly collapsed centrally, but there's bulging of the posterior margin. And this is because the vertebral body, as you can see on the axial image, is almost completely filled by tumor tissue. And what this then looks like is a bulging box, or as if you sat on a box full of styrofoam, or as if you're sitting on a bean bag and the whole thing just sort of bulges out. So to differentiate between the two, here you have posterior convexity on the left, and here on the right you have a fracture line with retropulsion. So the empty cardboard box or the osteoporotic fracture is on the right, and the bulging cardboard box or the malignant fracture is on the left. The next thing we're going to talk about is the multiplicity, or the second factor we look at is the multiplicity of these fractures. Now in osteoporotic compression fractures, what happens is you have multiple bones that are weak right next to each other, almost diffusely. Oftentimes these patients have abnormal curves of the spine. And along with axial loading, what you see is a domino effect. Essentially, one vertebral body fractures, and then the next one, and the next one, and the next one, and therefore these fractures tend to be contiguous. On the other hand, in patients who have malignant fractures, the fracture is dependent upon how much of the vertebral body is involved by the tumor. So if you have tumor involving multiple vertebral bodies at different locations to a large extent, then the ones that have more involvement are the ones that are likely to fracture. The ones that have less involvement are the ones that are less likely to fracture. So for example, here you have a malignant fracture of the vertebral body, which you can see with complete flattening of the vertebral body. And then you have an additional vertebral body lower down with this rounded T2 hyperintense enhancing lesion, which is a metastasis, but here there's not enough involvement of the vertebral body, and therefore the vertebra has not collapsed. Here's an example of an osteoporotic patient where you can see the bones are osteoporotic, but you can see that the fractures are almost contiguous. So here you see fractures of the L2, L3, and L5 vertebral bodies with somewhat sparing of the L4 vertebral body. So this contiguous fracture line is sort of an effect of the domino effect that you would see in multiple vertebral bodies that are weakened together. So the second factor we're talking about is the contiguousness of fractures or multiplicity of fracture lines. The third situation that we're going to look at is the presence or absence of spared marrow signal. So an osteoporotic vertebra typically consists almost entirely of normal bone, but it's just weakened bone, whereas and therefore it will contain fatty marrow. On the other hand, a malignant vertebral body will be completely filled by tumor tissue, and therefore in these situations you will not have fatty marrow inside them. There are the odd cases where you can have a small lesion and you have fatty marrow. So it's an osteoporotic vertebra with a met inside it. And here obviously it's very difficult to tell. If there's not much involvement of the vertebral body by the tumor, then the fracture could be more from osteoporotic reasons than from tumorigenic reasons. But let's not get into this. I think this is a slightly more complicated topic that we can discuss later. So here is an example of somebody with an osteoporotic fracture in the image on the far left. It's one that you've seen already. You can see the vertebral fractures, but you can see on the T1 weighted images that the fatty marrow is still maintained. On the other hand, when we look at the two images on the right, what you can see is there's complete collapse of the vertebral body, and there is almost no healthy fatty marrow within this vertebral body. And therefore, this is a classic example of a malignant fracture of the vertebral body. If we look at the fracture at the two vertebral bodies above the malignant collapse, you will see that they have got some buckling of bone, they have got some fracture lines, but there is maintained fatty signal. So therefore, it is one vertebral body with malignant collapse, and the two adjacent vertebral bodies actually have osteoporotic fractures, which is almost like the domino effect. Sometimes when you have challenging cases, we can use something called in and out of phase imaging, and when we use this imaging, it essentially helps us to identify the presence of fat within a vertebral body. So when we look at in and out of phase images, if there is fat within the vertebral body, you will see a significant change in the signal within the vertebral body, and this is usually a way of telling us that yes, there is fat, and therefore this is more likely to be an osteoporotic fracture. So if there is significant difference between the two phases, that suggests that it is a fat containing vertebral body or a benign fracture. The next element we're going to talk about is involvement of the posterior elements. Now remember, in compression fractures, especially in hyperflexion or chance injuries, you can have fractures that go through the posterior elements, and therefore you can see posterior element involvement in these cases. In patients who have tumors, what typically happens is that it is this venous flow within Batson's plexus and the posterior aspect of the vertebral body where the stagnation of flow allows the malignant cells to accumulate, and therefore the disease typically begins at the posterior aspect of the vertebral body. From there, it will move into the pedicles, and therefore when we talk about radiographic findings, we talk about a blown pedicle or that winking owl sign, and that's usually because of pedicle involvement. So when you see posterior element involvement by soft tissue or by tumor, then that's obviously a malignant lesion. Whereas if you see just a fracture line but no real, you see edema but no real solid tissue, then that ends up being a compression fracture. So let's say, for example, this is an example of a hyperflexion injury. You can see the posterior superior retropulsion, you can see the anterior wedging, and then you can see the fracture of the inferior articular facet of the upper vertebral body in this hyperflexion injury, showing you involvement of the posterior elements. On the other hand, in this case where you have a malignant lesion, you can see how the tumor has actually gone and involved the entire vertebral body, and especially on the right side where the arrow is, you can see the tumor extending into the pedicle, the transverse process, and the posterior elements, and it's doing it to a much lesser extent on the left. So posterior element involvement can happen in both conditions, but in osteoporotic fractures it will tend to be more edema rather than soft tissue, whereas in malignant lesions you will see soft tissue involvement. The last element we're going to talk about is something called a focal paraspinal mass. Now remember, whenever a vertebral body compresses or collapses, there may be a small hematoma that forms, but it tends to be fairly diffuse and surrounds the entire anterior paraspinal space. So the compression fracture can be associated with a little bit of soft tissue. When you, on the other hand, see a malignant lesion, that soft tissue tends to be more focal. So it will tend to be in one area more than the other, and it tends to be very diffusely soft tissue like, and it will tend to enhance really nicely. So if we look at this kind of lesion here, you can see this is a large focal paraspinal mass, and you can see the soft tissue that's extending around the vertebral body in somebody who has a malignant compression fracture. So if you want to find out more about this, this was a really nice article from a few years ago actually, which really nicely explains the situations from Radiographics by Tom Macaulay and a bunch of other people. It's a really nice article. I'd encourage you to review it. It sort of talks about how these are the 5 primary points that we would look at to differentiate these lesions, and then it also tells us about how these can be differently accurate and specific and sensitive. So remember, when you're differentiating between malignant and benign compression fractures, it's the fracture line, retropulsion and convexity, multiplicity, sparing of marrow signal, posterior element involvement, and focal paraspinal mass. So if we conclude by saying differentiation is pretty good by regular MR, but there are challenging cases and we have solutions for those. Just to review what we've talked about, when you're trying to differentiate between malignant and benign fractures, usually just a routine MRI is enough. You don't need to do anything more. The second thing is, when you have malignant collapse, typically you will have something called convex posterior margins, because it's the vertebral body that's stuffed with a large amount of tissue. The next thing when you have a malignant collapse is you will typically see random fractures which are dependent on the degree of vertebral involvement by the tumor. When you have benign fractures, you will typically see that they show fatty marrow signal. And when you have posterior element involvement, remember, you can see them in both, but they have a different appearance. They tend to be more edematous in those who have had a fracture, which is benign, whereas in those who have a malignancy, there will be soft tissue involvement. And when we look at paraspinal soft tissue, remember, you'll see it in both, but you want to differentiate a mass from a hematoma. So with that, I'll end this, and I hope that this helps you in terms of differentiating these two conditions with greater confidence in future. Thanks again, and keep up all your good work.